about ARPA funds all day, so off and on.
Well, that's,
Sorry,
oh, go ahead.
Right.
update on the property.
Is this the one that claims it's a church?
Right. Probably get our kids, which I don't. Essentially, road enough to be able to get in sometime to clean it up. I already sent it to Dave and Nora.
120 days. End of June, basically. Well,
We might not have it.
Hey, Jim.
Gentlemen, how you doing?
Hey, Jim.
You know, I zoomed in the planning commission, not zoomed, but YouTubed it. Did you YouTube it?
I haven't yet, but I will before next week's meeting, but no, I haven't watched it yet. I love having those available.
It really was nice, but no opposition, went right
Yeah.
through. So,
Yeah,
apparently
I
satisfied.
watched it yesterday.
Did you watch
I
it?
did. I think there was two on, it must have been you and me.
Yeah, it must have been, 'cause I was, yeah.
So they had the overlay district, right?
Overlay and the discharge. Of course, I think that may be part of the overlay anyway too. But discharge of firearms, they can hunt, as I understood.
I think in our community, if anything that has discharge of firearms, nobody's gonna be concerned if anything that said can't disarm firearms, we'd have a big crowd.
That's what I was gonna say.
Maybe a line out.
That's what I was gonna say, yeah.
We'd have to go out to the college, yeah.
The room would be full, trust me.
Oh, yeah, oh, yeah.
I'd be in that group, so that's okay.
That's okay.
nothing wrong with some good hunting.
True.
All right.
Yeah. Todd.
That's one we try on email to say she was not gonna make it tonight. He was questionable.
He told me he wasn't able to come last night, talk to him.
think I was trying to talk myself into not coming. I guess I'm glad I didn't.
Well, you could have watched it on YouTube.
Yeah, just didn't seem right.
So I had I saw it earlier this week. He said he was gonna
I haven't seen him around today.
Oh,
No,
there he is right there.
it's the same, not like I was outside looking.
Right.
Tried to stay in.
Yeah, I did not look hard either.
Yeah.
Presenter here?
It's on the TV.
He's gonna be on the next
Oh, I see.
snowstorm.
Spencer, are you about ready?
You know, I'm ready to go.
Okay, give me just a minute, we'll get going here. So,
Very good.
okay, well, by the clock in the back of the room, it is 5:30, so we'll start our city council work session here on Wednesday, March 9th, 2022 at 5:30 PM. I'm going to call the meeting officially to order. As I mentioned a moment ago, Spencer, our presenter, is going to be remote, presented on a Zoom meeting, I believe it is, or a Teams meeting, one or the other. Anyway, he's remote, and due to the snowstorm, otherwise he would have been here with us. So he will be presenting on our our subject tonight. Angie, would you do a roll call, please?
Nestle,
Here,
Traha, Bowles, Lucas,
Here.
Garrett.
Here.
Carmen, Reeker,
Here. Here.
Thank you. There is a current copy of the Open Meetings Act of the State of Nebraska is posted on the wall at the back of the council chambers, near the door there. During this work session, no formal vote or action will be taken at this meeting. I'll repeat that, no formal vote or action will be taken at this meeting. Our presenter tonight is Spencer Thomas from APTA Health, and he is presenting on the renewal of the city's health insurance plan. Since we are remote, I would remind everybody, if you're going to ask Spencer a question, please turn your microphone on because he is hearing us through the camera that's on top of that screen that's right here in front of me. So if you don't turn your mic on, there's a good chance he will not hear what you're saying. And not that we ever really have this problem, but please don't everybody speak at once because he'll only be able to hear really one feed of sound. And I'm sure he'll be happy to answer all our questions. Dawn, thank you for your efforts arranging this tonight. I know it took a little last minute, and Kevin from IT, we appreciate you being here. So with that, Spencer, I'm going to hand it over to you, please.
Wonderful. Well, I appreciate, and first and foremost, I was just gonna mention, I had every intention of being there in person. Ironically, I have been everywhere from Ogallala to Valentine to Lexington, and, been staying in North Platte the past couple of weeks. So I've been all and around North Platte. But when I made my drive this morning, over to Ogallala, the roads were bad enough that I know that I'm 10 feet tall and bulletproof, but I figured making it home to my family was probably an important piece, and the roads just, they were not looking great. So I appreciate everybody accommodating me and being remote. I sincerely appreciate it. So, I'm looking forward to tonight. I know I normally talk pretty fast, and I'm gonna try to intentionally, kind of go through everything in a fairly methodical way. I am gonna try to stop and make sure that if you have questions, I wanna make sure that we answer those questions. And so I know this is something that, we've kind of recently, started doing. And so again, I really wanna make sure that everybody feels comfortable with, what the city's doing. And really for the most part, this year's renewal was a really nice renewal. So I'm eager to present it and go through that. So before I start, is there any questions that anybody has on the front end? And or is there anything in particular you would like to get out of tonight's meeting that, coming into this, you would like to know more about?
I'm certain we will think of some questions along the way, Spencer, but we're going to let you talk first.
Okay, that sounds great. Let me just really quick, and I want to do this as again, as a high-level overview. I'm going to take just 5-10 minutes to review through the components of the program, and then I'm going to go through the renewal and go through all of those components. But I feel like, again, this is a good, the meat and potatoes of the way that this program is structured is, again, a good piece to review. And really, again, as any part of any self-funded health plan, you have a reinsurance carrier, which is really the renewal what we'll be talking about tonight. We have a pharmacy benefit manager, which I'll report on. We have wellness and biometrics, reference-based pricing, telemedicine, cost containment, transparency tools, utilization, disease management, all those pieces. And really all of that is typically spearheaded by your third-party administrator, which in the case of the city is Maritime Health. Again, one of the main structures that we have reformatted in your program in particular is that, again, there's misaligned incentives throughout the whole system. And when you're getting advice, when your members are getting advice directly from the insurance carrier, oftentimes those answers are going to be through the prism or through the lens of what the insurance carrier may want you or may want your members to do. And so by removing the TPA and inserting disease management and case management into the heart of the program, makes it so that way we can make recommendations to your members to be better consumers of healthcare. And that, again, is really what we're doing with Quantum Health. And again, as a reiteration, this is something I mentioned before, but it's always good to kind of talk about again. Quantum Health is the foremost leader in care coordination and navigation in the country. And they really do it really through a simple means, is they are giving all of the members at the City of North Platte a single point of contact, and more importantly, a single pod that your members reach out to in any instance, whether it's medical, pharmacy, disease management, case management. They are reaching out directly to Quantum, and that pod is located in Columbus, Ohio, and it consists of 30 members. So one of the beauties of what we've been able to offer to the city is that we are offering all of the members a single point of contact, as well as a smaller pod, so that way everybody gets to know the city as your members call in, as they're talking to the care coordinators. Oftentimes when they call in, it's very possible that they might actually speak to the same care coordinator, and that's something that we actually want to see. So by giving them that one phone number, again, we can empower those members to make those choices. And again, it's not just the member, it's the providers as well. Again, as we think about healthcare in our country, it's a very dysfunctional system where you kind of have the provider working with the insurance company and the provider and the insurance company working with the member, and it can be very confusing. And so one thing that I really want to stress is that the providers as well are calling and speaking to the same group of 30 individuals in Columbus, Ohio. Your providers, as they call in on your members' behalf, are actually speaking to the same group. And that's important because, again, we want to make sure that the information loop is closed as much as we possibly can, so that way, everybody is understanding what everybody is trying to do. And when you start getting into more complex situations, which certainly the city has seen, it allows for a greater level of communication between everybody. And that isn't just using the claims administrator in the network, but making sure we're looping in the pharmacy benefit manager, as well as more specifically point solutions. And that's something I'm going to spend a fair amount of time going through tonight as well, and how that all relates. So I want to pause here, and I want to show the statistics. And again, I've talked about this before, but I'm hoping that with giving that little bit of an intro, that again, it will give a little bit more credence to some of the numbers that I'm going to present on this side, because these are fantastic. So when you look at the report that I'm showing here, again, it shows the engagement by which Quantum has with your employee population, their spouses and their dependents. So Quantum has achieved a 66% level of engagement with all of your members, so across the entire board. They've achieved a 77% engagement with your employees and an 84% engagement with your spouses. And you can actually see in here, you can see a really large increase in utilization. And I think that's, again, I really want to give credit to the insurance committee. I think, they have done a really nice job in marketing this and making sure that employees have questions, that they're talking to the care coordinators. And so you can see that really precipitous jump in overall engagement with the care coordinators. The light green box, of course, is the prior 12 months. The dark green box is the current 12, and the spotted, column, if you will, is Quantum's average book of business. So, what you'll quickly see is, the city of North Platte is, certainly even above what Quantum's metrics are. Now, again, we want to show that breadth, if you will, the number of phone calls amongst your entire population, but we want to show the depth as well in terms of the number of phone calls, that are made on your employees and members' behalf. So each individual member have made an average of 4.4 calls to the care coordinators over the course of just the last year. And actually, this is, again, data January through December. Your employees have made an average of 9.9 phone calls out to the care coordinators. So utilization is really where we want to see it. And again, we report on this data because, again, most other carriers are not going to show these types of statistics because, again, the insurance industry as a whole is rather quite abysmal. And so, again, we want to make sure that this is working for the city, and I'll show in other ways where the care coordinators are making some good impacts. So I'm gonna kind of rapid fire through some of these slides. And again, if anybody has any questions, certainly feel free to, make those heard. The care coordinators will do pre-admission conversations where anytime anybody goes in for any type of procedure, they're going to be reaching and making proactive outreach phone calls to those members, making sure, you'll see the questions in the top right-hand corner, where they're asking your members, do you understand your pre-admission, instructions? Have you discussed and understand your pain management plan with your provider? Do you have a caregiver to help you, when you get home? Will you recover at home or someplace else? Again, these are questions that oftentimes members maybe not asking themselves as they go through this process. And again, this is with a nurse case manager, these questions are being asked. And, so not only is it pre-admission, but it's also post-admission. Do you understand your discharge instructions? Do you have follow-up visit with your primary care doctor? Do you have transportation to the procedures that, maybe your follow-up visits? And then again, because you're talking to a clinician, you're talking to a nurse, let me review your medications with you. Do you have any concerns about taking your medications? So again, this is really getting to a white glove concierge service where your members are getting the help and care that they need when they need it. So when you look at the overall conversations, and this number, anyways, it makes me excited when you see these things work. Last year alone, Quantum handled 1,109 phone calls on your group's behalf, just your group. This is City of North Platte only data. When you think about COVID and everything happening, especially as it related to healthcare and concerns around those, I couldn't be prouder of the fact that, we had this care coordinated service, this concierge, if you will, available to your employees, their spouses, and their dependents to make sure that they were getting the help that they needed and the information that they needed, especially through a fairly confusing year like we had last year, really the last 2 years. And you'll see, as you look at some of the questions that were asked, many of them were related to benefit education, verifying eligibility, but a lot of these were claims inquiries. Members asking about, what's going on in terms of, my claims, whatever they may be. Pre-cert referral, member provider assessments, where Quantum would be making proactive outreach on your group's behalf, as well as clinical. And clinical is another area that I'm really proud of. But again, it's not just the number of phone calls that I'm targeting. It's the number of topics per conversation, because the care coordinators are trained to make sure that they're identifying additional issues in the phone calls that they're fielding for your members. And you'll see over on the right-hand side that they identified 2.3 issues per phone call as they were working through with your members. If a member called in and said, hey, I need an ID card, the care coordinator is going to ask, again, hey, can I ask why you're asking for an ID card? Well, my son broke their collarbone, or whatever it may be. Asking those questions to make sure that your members are getting the help that they need. And then the last one is that half of these phone calls are actually being directed towards the provider as well, making sure that we're looping the provider in and making sure that they're on the same page as well. One other area that, again, I think is a big concern is certainly your high-cost claimants, because that's really where the rubber meets the road. You're a self-funded health plan, and we want to make sure that we're tackling those large claims. So you have 22 members that are identified as high risk, and we have achieved 95% engagement with your high-risk population. Inside of that, there's 11.7 average phone calls with your high-risk members, and 2.9 clinical conversations on top of that are being had with those members. So again, when you talk about, how important all of this is, again, looping in your high-cost claims, making sure that we're trying to drive down costs as best we can. Moderate risk, we had 9 members, 55% engagement, 4.6 conversations, and with 1 clinical conversation, and the last one is your low-risk population, which is interesting. We talked about this before. You have 348 members that are actually identified as even low risk. So again, this is something that that the city continues to work through, as do most municipalities. We have about a 54% engagement with your low-risk members, averaging 4.3 conversations, and 1.5 of those on top of that are clinical in nature. So I want to pause there, and I'm going to switch gears and kind of go through some of the other things that we have seen within your group. But let me pause. Does that stir any questions?
Spencer, this is Ty Lucas. A very quick question. It looks to me like our numbers of high and mid risk, mod risk moved down fairly significantly from last year. Do you want to know what that's attributed to?
So in terms of, so you're talking about moderate and low risk?
Yeah, it looked like our numbers, like if you combine the two, might be down as much as 40 or 50%. I just looked real quickly from the last presentation.
When we had that. So, again, I don't necessarily, Ty, I guess I'll just be straight with you. I don't necessarily know what to contribute to the drop in that moderate and low risk. Again, all I know is, again, that, particularly last year, a lot of individuals, weren't quite as involved in their healthcare as they normally were, given COVID. I don't necessarily want to just use COVID as a scapegoat either, but I might actually see if I can inquire further and get some answers on that.
Okay. No, that's okay. Okay, I was just curious if the criteria for those categories adjusted at all, or if it was just that the city has less people in those categories. So, in other words, did the people change or the categories change?
Yeah, I mean, again, this is gonna reset every single year. To my knowledge, the categories or the requirements in each category didn't change to my knowledge. So I don't think it was that side. I just think, it really could have just been that, in 2020, within 2021, people weren't reaching out quite as much that were in the moderate or low risk.
Okay. All right. Thank you.
Hey, Spencer, Brad Garrick here. How are you identifying your risks, patients? Is it based on HCC coding, or how are you identifying what's a high-risk patient versus a low risk?
Yeah, so kind of in a nutshell, if you look on this one, this is within the appendix. So this one's down at the bottom. I know this might be a little bit of fine print, so I apologize if it's hard to see. But you'll see members identified as having the most complex health solutions with highest risk for poor health outcomes, utilization, and cost. So the nurses proactively outreach telephonically to these members to, and their providers develop individualized plans and care goals and intensive management with frequent outreach. So really what it comes down to is these ones, we're not necessarily looking at like CPT codes. We're looking at risk factors, poor health, as well as utilization and cost. Does that make sense?
So it isn't based on claims data, it's based on your care coordinators and their interactions?
Yeah, I mean, claims are going to be definitely, utilization and cost are going to be one of the big drivers there. So that is going to be a big driver. But on top of that, they're also going to be looking at areas where poor outcomes may exist. So you could have somebody who may not necessarily be a high-cost claimant, but that, again, maybe they have diabetes and we recognize that they don't have good utilization of their diabetic medication. So outreaching to them more proactively to use their insulin, et cetera, may be a benefit. But I know that sometimes those folks can crop up on a high-risk report.
Gotcha.
Does that answer your question?
I think so.
I think so, yeah. And then just as a side note, moderate risk, again, in a similar bucket, and then low risk as well. So there, like I said, there's an appendix back here, and I can certainly send this report on the tail end.
If you would.
And you can thumb through that as well, if that's helpful.
Yeah, if you would, I'd appreciate that.
Yeah. I'll send this out. I know that I certainly have Matt and Don's email address. So at the conclusion of this, any reports that we go through, that you would particularly like to have, I can certainly bundle those up in an email, get those over to Matt and Don, and, make sure that they can, I know Don's in the room, so I'm hopefully not, inviting her to, do something, but, hopefully, we can get those over directly to you.
Thank you.
I'm not trying to sign up Dawn for anything, I know she's got a lot on her plate, I'm not signing her up for more, I promise.
She's smiling so far, so it'll be okay.
Very. So that's the quantum side of the house, and I wanted to just show some of those pieces. I wanna switch gears and go into, some of the point solutions that the care coordinators are using with the members. And then, like I said, I'll save the best for last, of course, the renewal. But I wanna touch base on a couple of quick things here, that I think will be of interest to the council. Pharmacy costs, again, when you look at it from an overall perspective, right now, pharmacy equates to about 25% of national averages in terms of overall cost. Within the next 5 to 10 years, with some of the specialty medications coming out, that really could be in the ballpark of upwards of 50% of the city's overall cost outlay. So that being said, and again, pharmacy has always been one that has somewhat plagued the city in terms of just high cost utilization. And so, one program that we put in place, we've actually got a couple of them. We not only have alternate funding solutions, but we also have where we can actually procure the medication from outside the United States. Again, it's no secret that inside the United States, we pay some of the highest costs for medications. And by simply getting those same medications from tier 1 countries, New Zealand, Australia, Canada, the United Kingdom, we can actually radically decrease the cost and the burden for the city. And I just wanted to point out that, again, we've got a number of medications on your group. We really have 4 of them. 2 of them are Dupixent, one is Vomerity, and then Stelara. In total, these 4 medications, in the month of February alone, would have otherwise cost the city about $26,886 alone. They ended up actually costing the city $3,401, netting in about an overall savings of $16,439 in net savings for the month of February. If you lump in January, year to date, this program alone, after targeting these medications, have avoided $36,124 alone in just overall spending for the city. I mean, this is, again, especially when you look at last year, we were just over $200,000. If you run this out, we would be in well in excess of $300,000 avoided through this one program alone by really, more than anything, just negotiating directly with the manufacturers on the cost of these medications. And again, this is where the beauty of self-funding is that you can really get scrappy and look for solutions to really bend trend in terms of cost. So I wanted to pause here. Does this stir any questions from any of the council members? I know it's all really exciting. Like I said, I know this is all riveting stuff. But again, when you think about the pharmacy costs in this country and trying to avoid what we can, there's a lot here. One other program that I wanted to just touch on, and I touched base on it last year, was Navrx. And again, this is a data warehouse, something that we own as a proprietary system. And again, we're not a PBM, we're not a TPA, but we utilize a service called Navrx. It's something that we built out as proprietary, where again, we're not only using some of the other funding mechanisms for pharmacy or the international RX, but we're actually working with members to change medications because again, we're going after the lowest net cost. Something that has kind of plagued, the insurance industry, if you will, is the chasing or the desire to chase rebates. And, another thing is structuring your formulary in a way where we're targeting the lowest net cost medications. And again, sometimes that's going to be your generic medications, and then sometimes that's going to be your brand medications. But it's no secret that the PBMs who have been, really highlighted in the news as of late, are really making a lot of money off the backs of these employer groups. Spread pricing would be a big one. Where, again, in a nutshell, basically there's what the PBM paid the pharmacy, and then there's what the PBM charged the employer group, if you will. Spread pricing is a big issue, even big enough that the state of Wyoming is actually taking up issue with that and looking at legislation following behind Arkansas and West Virginia and others. Spread pricing is an issue. But the beauty of, again, being self-funded and being on a transparent contract, we've had the city on a pass-through contract, for, a little over 6 years now, where, Magellan, your pharmacy benefit manager, is paying a certain amount to the pharmacy. They're passing that back through the city at, again, what they paid the pharmacy, and then there's just a per dispensing fee that the city pays on top of that. It just ensures that everybody's playing the way that they should. Now, what that opens us up and lets us do is now we're looking at the data to see, okay, hey, can we help your members look for and procure the lowest net cost medication? So looking at rebates, seeing if rebates are going to be, if they're going to be advantageous, and if they're not, switching that member to that lower net cost medication. In the recent 12 months, by simply switching medications, by working with your members, by working with the pharmacies, we've been able to save $36,967 by, again, just simply making sure we're targeting the lowest net cost medication. Since the inception, we're at about $133,000. And again, just simply working with the member, working with the pharmacy, and making sure that we're targeting those, those lowest net cost medications. So again, something else that we're really quite, again, proud of. If you have any questions in terms of what medications those were, we've got metabolic drugs, cardiovascular agents, topical agents, and again, most of the time these are smaller dollar savings, $600, $180, $170. But then when you start looking at the number of transactions that go along with those medications, because again, the city has quite a few members, that's where you start to add up and really see some significant savings. What I want to stress is that all these programs that we're doing, again, require a high degree of touch and education, not just with the member, but with the provider. And so everything we do, we work with a local provider to make sure that they're okay with it. We've had 32 of those approved. We have 33 that were denied. 33 physicians said, hey, I don't want to do that because of a given reason. And we shut that down right there. Then we reach out to the member and say, hey, is this something that you would like to do? We have 30 of those approved. And then, of course, one patient denied that. And again, we stopped right there. So 10 more are in progress, and we sent out quite a bit of communication from there. So we're excited with how that program comes in. And then on the heels of that, talking about rebates themselves, and how has the city done in terms of rebates. And again, rebates are no different than buying a TV. You go to an electronics store and Samsung and LG, they're priced for the same TV, they're priced the same. And so one way LG is going to get you to buy their TV is offering a rebate. All rebates are passed back to the city of North Platte at 100%. Now, another sneaky game that's often played in our marketplace is the PBM and others may actually retain rebates as an additional form of revenue. All rebates are, again, passed back to the city at 100%. If you look at just the first 2 quarters of 2021, again, you had $80,746 in Q1. Again, not a small dollar amount. That's in 1 quarter. Quarter 2, we had $70,190. So in 2 quarters from last year, we had $150,000 come back to the city of North Platte in just rebates alone. You want to take that back and look at 2020, we had $268,000 come back to the city, and again, in Rx rebates alone. So again, it's about looking at your program holistically and making sure that we're tackling all of the different components to, again, just make sure that we're looking at the program holistically. Oftentimes, some may look just at rebates alone, and by structuring your formulary in that way, again, you may be missing the ball because, again, you're missing, again, what is the lowest net cost? So we want to have our cake and eat it too. We want to target the lowest net cost medications and then garner in as many rebates as we can. So I'm going to pause here. Does that garner any questions before I switch gears one more time?
So just so I understand, this is Brad again. Those are monthly scripts then. They're not emergent care or something along those lines, correct?
Ask that question one more time.
So these are monthly scripts that you get every month. It's something, and instead of going to your local pharmacy, they come in the mail, correct?
So both. Rebates can be attached to both mail order as well as, prescriptions picked up just at the local pharmacy as well. So this would be any prescription. And is that what you were getting at?
Yeah, I was just curious how how the workflow functioned. So interesting. Yeah. Thank you.
And we are encouraging your members, to further that question and, again, give some more color to that. Again, we're encouraging your members, to use mail order where applicable. Again, it's kind of the idea of Costco. Again, if we can procure just the medication at a lower net cost, because again, every pharmacy is gonna be different, even within North Platte, pharmacies will charge different amounts for the same medication. And so we're going to look at mail order. A few years ago, those were really being pushed because the PBM could double dip. They were encouraging mail order because the PBM was the pharmacy as well as the PBM, so it was a way for them to make a few extra bucks. We're not really that big on pushing mail order, only unless we know that Magellan can actually get that prescription for less. And that's typically gonna be your specialty medications, oftentimes. So it's, again, the equivalent of purchasing through Costco. Magellan buys en masse for the entire United States, for their clients, that is. And then they can ship those medications directly to members' home. But yeah, there's gonna be rebates associated with mail order as well as local pharmacy claims. So hopefully we'll actually cover there. Any other questions that drops?
Could you walk us through, what does this look like for one of the city's employees? So let me just give you a scenario. If someone, an employee needs a prescription for something, doesn't matter for what, and do your care coordinators review their prescriptions from the provider and then call the provider and suggest that they should use drug B instead of drug A, or what does this look like in the actual process?
Yeah, you bet, and that's a great question. So I'll actually give you a little bit of a sneak peek into how the Navrx platform, so what's actually happening on the back end. So let me, I think this will be of at least interest. So on the back end, this is what we're seeing on your group. We're seeing all of your prescriptions, that are being prescribed, and we can see them each month. The care coordinators can see a summary view, and they can see the drugs that are being prescribed, and again, if you look, and it'll be kind of hard to see on your screen, but if you look at like Stelara right here, right over here, there's a little dollar sign. You gotta love the marketing side of things. And it shows me right here that this is available for alternate funding, international RX tourism, or specialty review. So what that's gonna do is it's gonna prompt the care coordinators to make an outreach first to the provider's office. So they're gonna call, and let's say that this Stelara was one that was up for maybe switching the medication, or even having mail order. What they're gonna first do is they're gonna reach out to the provider's office and say, hey, we have Spencer here. He's taking Stelara. We know that we can get this medication, for less if we were to switch his medication to, a different medication altogether, or that we can get this cheaper by actually mailing it to their home. If it's mail order, that's one that's kind of more seamless, but if it's a switching of the medication, then that's when the care coordinator is gonna ask the provider, are you okay with us switching from, Stelara to, like a Tecfidera or a Humira? And the provider may come back and say, look, we've tried Emerald, we've tried Humira, and Stelara only seems to be the medication that seems to work for this member. The care coordinator say, great, basically end of conversation. But if the provider says, you know what, actually we haven't tried Humira, or we haven't tried Emerald, and I would be okay trying that if it's a lesser cost, because again, keep in mind, I don't expect a primary care doctor or a specialty doctor to know the cost of these medications. They just know, hey, it's, these three medications are in the same class and could work for this member. And so that's what the conversation the care coordinators have with the provider's office is, hey, if you haven't tried these other medications and you're okay with it, we'd love to switch your member to that medication. So the provider says, yay or nay. And in your group's case, a lot of them have said yes, and a few of them have said no. If they say yes, then a proactive outreach goes to the member to say, hey, Spencer, we've talked with your provider, Dr. Smith, and, he okayed moving you from Stelara to, Tecfidera or Emerald or Humira or whatever it might have been. And, this will also result in a lower copay for you, the member. We always want to make sure we're advocating the benefits of how that might save the member as well. And say, your doctor approved this is the impact it will have on you, are you okay with that change? And if they say yes, then we actually proactively outreach the pharmacy to have that medication changed over for them.
In approximately what time frame does this usually occur? So the person sees a doctor at 10 o'clock in the morning. Is this resolved by 11 a.m. or? I'm just asking because often people, the doctor's offices are 2 blocks from the pharmacies here in North Platte. So somebody goes to the doctor electronically prescribes, they've probably picked up their medication in most cases within an hour at most. So I'm just curious, what does that look like on your side?
You bet. and we try to keep this as simple as we possibly can. So typically, it's that fill that triggers the outreach. So, we come in here and we say, hey, we see that the member filled the Stelara. So we're gonna let them fill that medication. And then over the course of the next 30 days, while they're in between their fills, that's when we're gonna reach out to the provider's office. It certainly, requires the provider's office to either answer the phone or respond. So that could take a few days. Then, of course, outreach to the member, that could take a few days. So this is typically done after the first fill, and then, done, prior to the next fill. So it's certainly not a process that happens within a couple of hours. It's human interaction, but we try to make sure we get that accomplished prior to the next fill. Does that answer your question?
Yep, that answers, thank you.
Perfect, very good. Any other questions? And these have been great questions so far, and this is what I'm hoping is that this is a work session, and you guys get an opportunity to, pepper all the questions you have. Okay. Let me just, and like I said, this is all, of course, to wind up to your renewal and how your group is looking. Just the last thing that I would just touch on in terms of reporting is, again, how your group has run from an overall perspective. And so again, I'm gonna actually blow this up a little bit. I see everybody kind of scooching towards the screen, I promise. I'm not trying to make this small. But as you look at, your group and how they've ran each month, you have, April through January, we have data through January, your employee population, medical claims, pharmacy claims, total expenditures, 4.2 million. So that number's, right here. So again, we've had $4,283,316 in gross medical claims paid. Then you take out your aggregating specific and your stop loss reimbursements, and you come to $424,903 in reimbursements that the city of North Platte was not responsible for paying. So that brings you to really, through 10 months of your contract, that brings you to $3,723,412. Now, that's where I'm gonna springboard kind of into the next piece. As you'll remember, the city has protection on each individual member, but a few years ago, the city opted to do away with aggregate protection, which I think has actually bode really well for the city. So as I show you and take you over to the renewal, like I said, you're going to see basically just really all of your fixed expense in terms of specific deductible. Now, that being said, keep in mind that we shop everything in-house by our own W-2 underwriters. And again, that's something that, we think is a big deal because again, because we don't take any commissions, rebates, overrides, or anything, we don't accept any dark money, as we like to call it, from any of our markets. So that really gives us an opportunity to really market your group to over 30 A-rated stop-loss carriers every single year. So like I said, there's a lot on this page. I'm gonna try to walk through them quickly.
Spencer, hold up, we got a question here.
Yeah, go ahead.
Spencer, I'm kind of curious, the expenditures that we had this year, how do they compare with last year's?
So, great question. So, here, I'll switch back to that. So, this is your report from this year. I'm gonna back out my screen real quick. So one of the things that I like about all of this reporting is that I can actually toggle between, the various years. So let me log back in because I didn't move quickly enough. If I look at your illustrative ag rates, come over here, I can pull up your claims from all of last year. So same report, you're gonna see the same thing. If you look at where you were aggregate eligible.
You're gonna have to zoom, Spencer.
At 4 million, here, let me blow it up again, sorry.
Thank you.
You ended last year at 4,182,000 in aggregate, or what would have been aggregate eligible claims. So in a nutshell, if you really take, again, very, very simple math, if you take the 3.7 million, so here, if you take the 3.7, so the 3 million, the 3,723, so the 3,723,412 divided by the 10 months times 12, that would put you at about 4.4 million. Last year, you were at about 4.1 million. Trend, again, medical trends, and again, something that we talk a lot about in this industry is, anywhere, conservatively, probably about 8.5%. So if you look at really where the city ended up, you were, just shy of, probably right at about that 8 to 9% range. Now you could also make an argument, for a more rural area, trend tends to be a little bit higher. Competition, again, it's not necessarily, metropolitan city where you have, 2 or 3 hospitals, et cetera, more providers to go to. But I would say, in comparison to last year, the city's sitting right at about, medical trend in terms of your claims expense. Does that answer that question?
So if I'm understanding you right, we're about 8 to 9% higher cost than last year.
That's correct.
What do you attribute that to?
So, I mean, again, one of the things that we have noticed, and actually in some of your large claimants that you've had, sadly, in 2020, we saw a pretty precipitous drop-off of medical care in terms of preventive services and the like. And then that also, attributed to in 2021, we noticed, again, in talking to our stop-loss carriers and looking just at our own data, that COVID didn't really break even the top 10 largest claims, even for some of our national carriers. So COVID itself was really not a big player. But cancer continues to be in the top 4 of the top 5 highest cost drivers. Cancer continues to be that biggest cost driver. And it grew last year in particular because members were not oftentimes seeking their preventive care. And so we were treating or catching cancer later. You do have a couple of cancer claimants on your plan. But again, you also saw an influx of claims because people were now returning back to seeing their doctors and maybe getting things done that they hadn't in previous years. So when I look at your large claims report, actually, let me just switch gears here real quick. If you look at your large claims report, over the last few years, and I think this is kind of an interesting piece to look at. If you compare 19 to 20 to 2021, you'll notice something very interesting. You'll notice that the city of North Platte went from 29 large claimants, and these are claimants in excess of 50% of your spec deductible. In 19, the city saw 29 large claimants. Last year, you saw 31 large claimants. And this year, in 10 months, I mean, again, it's pretty credible data at this point, you've only had 14 large claimants. So then you look, okay, so we haven't seen a lot of large claims. But then you come down to the actual claim size. So again, the average claim size in 19 was 121,000. In 2021, 19 was 121,000. In 2020, 111,000. And this year you're sitting at $117,000. So really what that tells you is that you saw a large increase in the utilization, not of large claims, but of smaller dollar claims. And again, that's going to be attributed to just higher medical costs in general. But clearly your group has seen a higher utilization in terms of smaller dollar claims. Does that help kind of shed some light on that question?
It does. I'm not sure why that would be, but it's kind of an interesting number, I think.
It is. One other area that we can always kind of look at when we look at your claims detail. And maybe this might go to, and this is why I like all of this reporting. So I can actually come in here and filter. So if we look at just, so let's just take a look at, for example, let's just take 2021. So we'll look at 2021 first. If I come in here and just filter out just 2021, and we look at just solely claims that existed, for 2021. I can always compare that and bench that. So, again, if you come down and look at the total, and again, these are gross dollars. So now we're not even looking at spec claims. This is just raw dollars that were paid out. Last year, you can look at inpatient hospital, inpatient psychiatric facility, other places of service, office, home, etc. But you can see $5.5 million. Your largest spending category, if I look at just this one alone, symptom and signs and the abnormal clinical and laboratory findings. Again, it's fairly generic. That's on the left-hand side. On the right-hand side, I can actually filter that down even further and show that, again, the bulk of these are imaging and outpatient, followed up by outpatient hospital, and then you can come over to office and emergency room. But if you actually look at the procedures in particular that existed with this population, that will tell you again what we're seeing in terms of those dollars beneath. So again, you get more specific. Office outpatient established low. We had $20,000 there. We had some abdomen and some other things. 15 members that were affected, $48,000 there. So. Again, and maybe I can go back through this data and in some follow-up kind of provide you some of these lower level claims and what we're noticing. But from a high level perspective, again, it really has been just a low level utilization, a higher utilization of kind of low level services. And like I said, I'm happy to kind of go through that and provide some more color to Matt. to go through and kind of show the difference between 2021 and 2020.
Well, that's satisfactory, thank you.
You bet. That's a great question. Does that draw any other questions from anybody?
Doesn't look like it.
Okay. I know we got about 15 minutes, so I'll, like I said, save the best for last. So in terms of, again, reinsurance, again, this is where, the meat and potatoes of your program. This is where everything comes in. So, again, I always want to make sure we're comparing to the current year. We have a $110,000 specific deductible with $135,000.
Hey, Spencer, you gotta make, Spencer,
Oh, yeah.
you gotta make that a lot bigger, please.
You bet.
Thank you.
There we go. Is that better?
That's much better. Thank you.
Very good. Okay. So again, just kind of start to finish. Your current carrier, you're currently with Gerber Life. $110,000 specific deductible. That's again on each individual member. That's what the city is responsible for each individual, member and their expenses within the contract year, which of course would be April through March. Then you have your aggregating specific deductible, meaning that the next $135,000, whether that's one member or 10, the city's going to take on the next $135,000 in claims. And then that's all going to be bundled by a 12-18 contract. So that is meaning basically the city has 12 months to incur the claim, and then you have an additional 6 months to report that. So the reason we do a run-out contract specifically on ISL claims or spec claims as these are, is that, again, you can do a run-in contract, oftentimes a 24-12, but again, I don't think that's going to be in the city's best interest because, again, it's all about known risk. When you have run-in claims or you're using a run-in contract, again, you might have a large dollar claim sitting out there that a carrier could laser. The beautiful thing about a run-out contract is that, again, the carrier agrees at the beginning of the year, and whatever happens, they're going to be stuck with those claims all the way through run-out. Most groups have a 12-15 spec contract. One thing that, again, I'm very proud of is that, again, the city has a 12-18 contract, which is, again, an additional 3-month tail over standard to make sure that we're getting those claims reported and nothing falls out of contract. So, that being said, total annual fixed costs from this year were just over $1 million, so $1,043,556. In that, $700,439 was the premium paid to your reinsurance carrier, in this case was Gerber Life. $343,000 of that was going to be in care coordination, navigation, TPA services, and the like. So again, as I mentioned, we don't have an attachment point or aggregate coverage on your group, meaning that, again, we're just going to pay claims as they come. And again, that's fairly well for the city, and I'll show some different numbers in our overall recommendation. But again, that's why you're just going to see on this one, you're just going to see, just your fixed costs. Now, this year, the city did have an additional laser liability, and so that, again, so overall, with the aggregating spec as well as laser risk, in the current contract year, the city was sitting at $205,000. So, again, just making things fairly brief, we go out to the market and say, hey, provide us your quote. Gerber Life came in, keeping everything current, they came in at basically about an 8.9% increase on your overall costs. That was, again, out the door. We told Gerber, look, we've gone to all of these other markets. We've gone to Symetra, we've gone to Granular, we've gone to HCC, we've gone to all these other markets, and here's their numbers. Are you willing to revise those numbers for us? Keeping everything the same, they came in and said, okay, we'll actually come in with a 2.1% decrease to your fixed costs, or in this case, about $22,000 in overall fixed cost savings. One other thing that they stepped up is plan mirroring language. So one other thing about being self-funded is that, again, there's what the plan does, and then there's what your reinsurance carrier is willing to reimburse for. And sometimes some groups will fall into a seam where the plan document doesn't always match up with what your stop-loss policy says. Now, that being said, we actually have in-house legal counsel, and our legal counsel every year actually reviews all of our stop-loss policies as well as the plan documents to ensure compliance. So we've been able to mitigate that up to this point anyways. But through our negotiation with our stop-loss carriers, we've actually been able to get them to agree to what's called a plan mirroring endorsement, meaning that the stop-loss policy, in essence, says we will follow the plan document, no questions asked. So it just makes it for a better contract. You're on a 12-18 spec contract, you have a plan mirroring endorsement, it really limits the possibility that we could have a legal spat with your stop loss carrier, because they're in essence saying that the plan document is the governing document. So Gerber did come back and say, okay, not only will we do a 2.1% decrease, but we'll give you your plan mirroring endorsement. I'm gonna just cut to the chase and go to the carrier that I'm recommending, and that is going to be HCC. HCC came in very aggressively. It's a direct carrier. Actually, HCC is owned by Tokyo Marine, which is the largest reinsurance carrier in the country. And they came in and said, look, we'll keep everything consistent, 110K spec, $135,000 aggregating spec, 1218 contract. We will also do the plan mirroring endorsement, but we will trim your cost by 5.8% on the fix. So that's where we actually start getting into a spot where, the city's now saving, roughly $60,000 in fixed expense. But the big thing that they did is they actually lowered your laser liability as well. They didn't think that your large claimants actually posed that much of a risk. And so they actually lowered that to a $30,000, or $40,000, net laser risk on one individual, bringing your overall actual net renewal to a 7.3% decrease. So again, that's going to be our recommendation for this year, is actually switching your stop loss carrier to HCC, picking up the plan mirroring endorsement, and then actually shaving off a little bit on the fixed and on your laser. Now, there's two sides of this equation. That's the first, that's the fixed. And then there's the claim side of it, because I want to make sure that the city is budgeting adequately to what your risk is. So this is a document that I put together. Let me blow this up as well. This is a document that I put together every year, for the city in terms of where we'd like to see your funding strategy. What does it actually mean to the taxpayers of the city of North Platte on what is this going to cost? So you can see your current year, where your funding rates are, and where claims came out at, and where our budget and surplus is. This year, I'm working with Matt. We are going to recommend that the city do a zero or a flat increase to the city's budget. That would include any kind of premium increases to employees as well. So again, we recognize that we really want to keep those premiums really aggressive for employees and their dependents, but also be aware that the city has other obligations that they're fighting this year in terms of inflation, and this is one area that we don't think needs to have any inflation. So our recommendation actually going into next year is a flat increase to the overall budget. The way that I get there, and I want to show my math, is I take what your current claim spend is, get to a overall, really what is our average spend this year, and then I'm even grossing these claims up by a 6% trend number. So I'm actually saying, okay, I'm going to take what your actual spend is this year, average it out for 12 months, and then I'm going to inflate that number by 6%. So I'm already assuming that your claims will increase by 6% going into next year. And then it goes, may or may not happen. We have our fixed expense. We have our RX rebates that we're estimating for next year, which should be a lot higher because your rebates have actually increased. So I anticipate that the city's medical spend next year will be in a ballpark of about $5.4 million. If we actually keep rates the same and everything else holds true to what I'm assuming, I actually think that the city would come in, within about $52,000 of that estimate. So there would be, potentially about a $52,000 shortfall or deficit, going into next year if everything holds true to what I was assuming. The reason I assumed a 6% trend line is because if you actually look at the last few months that the city has experienced, your claims trend has actually decreased. So, again, a lot of your claims, spike really towards the end of the year because that's when everybody's deductibles and co-insurance expire. And so, again, we oftentimes see a little bit of a decrease in overall claims utilization, going into February and March. So with that, the last thing that I would just mention, and this is something that I think the city of North Platte should be very proud of, is that, again, you want to be very judicious as you have a self-funded health plan. And so to this point, the city has been able to actually accumulate a $4.4 million reserve account in the event that there is a bad year. That is a rainy day fund. And I would really look at that as, every year I make these assumptions on how the city's going to run and, really where do I think things are going to wash out at. And, because I'm being conservative in a lot of my estimates, the city turns out ahead and, really over the course of the last 10 years, the city's been able to amass a fairly sizable reserve account. And again, this is to safeguard the city in the event that there ever were to be a bad year. So I see no problem tapping that reserve account in the event that we actually see more claims expense than we actually do. That's what the reserve account is for. So in a nutshell, your fixed costs are going down, care coordinators are being used, our pharmacy solutions, I think, are achieving some great savings, and I think we can go into next year with no increase. Again, something that not a lot of groups are looking at, particularly this year. So, I'm gonna pause there. Questions that draws?
So, oh, go ahead.
Go ahead, go ahead.
The laser liability, is that tied to the stop loss? Is that what that is related to?
That's correct. So basically, again, stop loss is known risk. So if you have somebody who has known risk that is gonna go above the $110,000, the carrier can do one of two things. They can either increase your premium to pay for it, or what they will call laser. And so that one individual will actually have a $150,000 specific deductible rather than the 110 like everybody else, that the city will be responsible for on that one individual person.
Gotcha. I noticed earlier in your presentation that your care coordinators have great engagement, which is awesome. Do you guys track any of the outcomes that come from it, lowering HbA1c or readmission rates or increasing, colorectal cancer screening, things of that nature?
So that is something we are working on with Quantum. So we own our own data warehouse. So all of the reports that I'm showing you are actually, reports from our own data warehouse. It is high-tech certified. And so one of the reports that we've requested from Quantum to load into our data warehouse is outcomes in terms of some of the things that you very much so mentioned. So at the moment, we don't have some of those reports, but that is something that we are working on.
So I assume you're going to go through your HEDIS measures, your normal suite of those.
Yeah, we want to. I want to hold Quantum's feet to the fire. They say they're really good, and that they have an impact on all these things, and we want to track those absolutely. So, and again, what I like is that we're going to be getting the data, all of the raw data, out of Quantum, and that's something I know is actually in process now. So that way we can ferret through the data ourselves to actually independently verify that they are having an impact.
Will you be able to load your historical claims data and look back to see trends?
That's something actually I will ask if that's something that we can look at historical data. So that's something that, if it's okay, I will follow up on.
Perfect. Final question. HCC, the carrier you're recommending, do they have any provider networks or anything that they're going to hold us to, or is it if you like your doctor, you can keep your doctor? I've heard that one before.
I guess I'm not going to be the one in the room here saying if you like your doctor, you're going to keep your doctor. I think that was a promise probably not well made. But that being said, the switch to the stop loss carrier genuinely has no impact on the employees. This is all something done behind the scenes. And that's where that plan mirroring endorsement comes into play, because the network actually comes from your TPA, which is Meritain. And we're utilizing the Aetna network, and that's really where members select their doctors. So I can say confidently that by switching to HCC as your stop loss carrier, that will have no impact on the network, because that's not changing. Does that make sense?
Okay. Is there going to be a network change with Meritain, or is it going to be the same as last year?
No change on the network. We're just recommending staying the same.
Perfect. I'll leave you alone now.
These are all great questions. Any other questions?
Yeah, I've got a few questions for you, Spencer. Can you show us, can we look at the trend report that breaks down the average cost per employee that we've looked at historically with you?
So that one is going to be, let me make sure I'm going to go right. Over plan. So that one is going to be this trend line. So this one, is this the one that you were talking about where it breaks out each month, where we're looking at claims and enrollment and what that spend has been each month?
Well, what I'm looking at, I'm looking at the last one that we looked at, but it ran from 2010 to 2020. And it showed us the average number of employees in the program. Like, for example, in 2020, we had 267 average number of employees at an average cost of $21,752. And so I was wanting to see what our next column looks like on that.
You're talking about the cost per
I know
employee.
exactly what you're looking at.
Yeah.
I have not updated that report because we're kind of switching over to having everything come out of SIR. But here's what I will do. I will rerun that report. That's just something that I've manually done myself over the years, just because I think it's a good report. So I will put that report together myself, and then I will include that in my reporting package if that's acceptable.
Yeah, no, thank you. I appreciate that. Do you know if what the answer is on our average annual cost per employee from 2021?
Really, what I could, here's what I could do, at least for back of the napkin math, at least for this discussion. Let me just do this, hold on. And this is again, just gonna be kind of back of the napkin. So if you look at this report, again, this is gonna show you, you're sitting at $3,723,412 in total paid claims. So again, just doing something really quick, if I take that number, so 3,723,412 divided by your average enrollment count, which is 1,446. Again, rough numbers, you're sitting at about $2,574.97 in claims, but I want to add fixed to that, and that's something that I can work on.
That's almost $2,600 per person?
$2,600 per employee, not member, correct. And actually, you know what, now that I think about it, hold on. Actually, one report that I know that I can pull, let me do this one real quick. This one will actually include, so this one is actually gonna include all of your members per month, and actually, Ty, I think this might actually be, it won't have all the years, I wanna complete that one for you, but I'm gonna probably use this report to get to that one. It has all of your employee counts, your medical, pharmacy, vision, all of those good things, all of your administrative costs, and then it's gonna also show you your gross monthly costs. And this, of course, will be inclusive of fixed costs. So with that, you're gonna be looking at, I wanna make sure I give you the right one. You're gonna be looking at about $2,927, including fixed costs per employee per month average.
Okay. About 2927, let me.
And I'll read you, like I said, and I know the exact report, Ty, that you're talking about, and like I said, that was just one that I was putting together. I'm happy to read you that one.
Well, we should look at that data because that would come out at 35,000 an employee. If that's a monthly average, that would seem wrong.
Yeah, that doesn't seem right. That's
No.
very expensive.
I mean, I know we're high, but I don't think we're that high.
Yeah, I'll go through and rerun that exact report. I have it saved in your file, and I'll go through and update that one for you.
And I guess I was gonna ask also, could somebody give us a quick refresher over what the offering is to the employees? In other words, what options they have, and then remind me what any cost sharing is?
Yeah, you bet. Let me switch gears here. I'll just pull up your SBC. Right here. Let me do this one. All right, so now again, just keep in mind, I'm just gonna share, just for purposes of this, for this meeting, again, just realize that there are actually two plan designs. There's one for the city employees, if you will, and then there is a different plan offering to the union folks. So just keep in mind that there are those two different plans. They're fairly similar, but this is, of course, is gonna be the one for the majority of your employees. Right now, we are sitting at a $750 deductible for each individual member, a $1,500 deductible for families. So again, and that's embedded. So that could be, two individuals, and if you have a third in your family that incur costs, your deductible will be met. The out-of-pocket maximum is sitting at $3,500 per individual, and then $7,000 for a family. So those are kind of the big ticket items. And then as you scroll down and you look at your primary care doctor copay, $15. Specialist is $30. Of course, preventive care, there's no charge for preventive. And then the city, after you meet your deductible, the city is covering 80% of the cost in terms of coinsurance for the member's health plan, above and beyond the deductible up to your out-of-pocket maximum. You also have a few copays in here, $10 for generic medications, $30 for tier 2, $50 for tier 3, and 30% coinsurance for tier 4 on those drugs as well. And then, $75 copay for urgent care. Mental health is covered the same as your PCP, so it's a $15 copay if somebody wants to go see, mental health services. And like I said, most everything else is covered deductible and coinsurance.
And then what's the coverage for employee versus in spouse versus family in terms of contribution or what they pay or don't pay as part of it?
You bet. So let me pull up that one. And this one is this is a spreadsheet that we have used. This is one that we have used for quite a few years. So Dawn is I think quite familiar with this spreadsheet. So if you look, there's a lot on here, but this is the one that I could access fairly quickly. So of course you have your budgetary rates. You have, single, and again, there's, this is all broken out, police versus fire, so there are different rates. But in a nutshell, basically what the employee contribution is for a single is $107.58. And for family, it is $275.54 per month.
Spencer, I think that's bi-weekly
Yeah, I was gonna say.
on that.
Oh, is that bi-weekly?
Yes.
Okay.
Okay,
So our monthly contributions, and then, okay, yeah, Don, I would defer to you. I know that that's something, yeah, anyways, I'll defer to Don on that one.
okay,
Oh,
s-
yeah, well, actually, it's right here, half of monthly EE contribution, so that's right, yeah.
okay, so a singly covered employee is paying 107 a paycheck, or twice a month. And for a family, and I'm sorry, I'm not trying to frown at you, I'm trying to read my eyes aren't that great.
Oh, no, I don't think you're frowning at me.
At 275 for a family, so you take that times 2 to get a month, or times 26, I guess, or whatever to get a year, is that right?
We do
Or
the
24, that's right, okay.
So they're paying, I guess if you wanted to look at it, instead of doing it this way, yeah, I could just take this, times 2. So yeah, so that monthly rate is $215, and then same here, it's gonna be times 2, $551 a month.
Okay. Great.
And from a national average, one thing that I would just point out, when you look at national average data, I think the city's pretty competitive in terms of premium on the employee side. The city is definitely very aggressive in terms of what they're charging for the family rate. So Kaiser Family, which is a big outfit that really looks at national averages and the such, I know that the family rate is a fairly aggressive rate in terms of, being lower than the national average. So, again, this is something that the city is welcome to set, and because we're recommending a flat increase, these rates, theoretically would not change either. And that's again, if the city council says, yeah, we're gonna take a flat increase to the city and to the employees as well.
And Spencer, at this point, we're not offering a HSA option that has a zero co-insurance, right?
Correct, there's just the one plan design.
Okay.
Now, if the city council, again, the beauty of being self-funded, and again, Ty, I think maybe we've talked about this in previous meetings. I actually think that there's a lot of wisdom in high deductible health plans with an HSA component to them. It doesn't make a difference to us if the city offers 2 plans or 3 plans. We're already offering 2 plans, if you will. We've got the standard plan, if you will, as well as the police and fire, the union plan. But if we wanted to offer a 3rd plan, if you will, that is a high deductible health plan that has an HSA component to it, there wouldn't be any kind of change in terms of fixed cost on our side. Again, we're happy to offer as many plans as really the city wants. But I do think that there is a lot of wisdom in offering an HSA account with a, better said, a high deductible health plan with an HSA element to it.
Well, what I keep thinking about, and we've been talking about this for a number of years, is I'm happy to see it stay level, but I think we're still, $4,000 or $5,000 per employee cost per year higher than we should be, based off the comparability data that's out there and just what I've seen out in the world. And I'm sure there's better data. I don't know if that's 3,000, 4,000, or 5,000. I think what the employees are paying is fair. It seems like we got a good plan that's taking care of people. I'm not looking to change anything there, but I think we've got to develop some strategies to try to move towards more towards the averages. Spencer, what data are you guys seeing for cities and counties in this part of the country, similar size range? Do you agree that we're $3,000-4,000 at least high on a per cost per employee basis?
So, I don't really, and here's why. So we work with, and what I may actually do, and I think, Ty, this would be a good exercise, I think just for you, again, we have over 250 self-funded clients domiciled in 25 states. We have a number of municipalities that are your size, and we have them actually pretty locally, not only in your area. So I could do a couple of things. I could look at other municipalities your size in your area, but then I can also look at municipalities in other states, so we can kind of get a little bit of a broader picture in terms of, what their costs are. The last time I looked at that, and I actually think it was in preparation for last year's meeting, I actually think the city is not really that far off in total overall costs to where your peers are. Because again, keep in mind, deductible means everything. So a lot of employer groups, the national average deductible is $2,200. The city is offering a $750 deductible. That is going to have an impact on your overall costs. And I think that's kind of tied where you're getting at, which I think is a good point. So I think if you look at your plan design, as well as the fact that you are a municipality, which municipalities tend to be a little bit more expensive. You're also in a rural area, which also tend to be a little bit more expensive. I think when you add in all those components, I don't really think you're that far off, but I want to actually put that statement, I want to put my money where my mouth is. And I think I can run a couple of different good scenarios for you and show you some comparability to peers in your area as well as peers in other states.
Yeah, and I know you guys have heard this from me before, but what I'm getting at is I think we've got to figure out how to get those costs down significantly. I mean, our company's not comparable, we're a different industry, but I think we're in at 13 and change per employee. And a lot of private, I think that's generally where the private world is, 13 to 15,000. I understand municipalities run a little higher. And I'm not trying to take away anything from the employees. What I want to see us do is get these health insurance costs managed, and I don't know, it doesn't seem like we're having any new strategies to accomplish that, and try to come up with some real good strategies to drive this down and bring it back into our wage pool. I mean, that's what I'm looking for, is to still have high quality care, but I continue to see this cost as a big anchor around our city in terms of accomplishing what you need to from a wage standpoint. So I just hope we can keep working on that. I know we talk about it every year, but we're not adopting any new strategies to significantly cut some cost out of this plan, which I think's very, very expensive.
So, Ty, I think that's a good point, if I may. And I do really wish I was there in person. Again, as I look out the window, I'm kind of grateful I did come down. Ty, I guess I am gonna disagree with you on terms of strategies that have been adopted, and I'm gonna go back and I'm gonna point to two programs specifically. When we talk about plan design and we talk about what that plan design is gonna do, that is to a degree gonna just shift costs. If we go to an HSA, you're going to shift costs to the employee. Now, in theory, many believe that by adding some of that cost to employees, that they're going to become better consumers of healthcare. And then that data does not always bear through when you actually look at, actually quite a few employer groups have gone to HSAs and have migrated away from them. Now, I think an HSA, if used correctly, again, and you're actually saving those dollars and putting dollars away, I do think it can have a positive impact, particularly for some of your younger employees. Now, when you look at your pharmacy spend this year alone, again, because of the prescriptions that your members are taking, and again, these are things that, again, you can't necessarily touch and say, look, I'm going to not allow you to take that medication or what have you. The city's expenses would have actually been upwards of $300,000 higher had we not installed alternative pay. And that's again where we are directly negotiating with the manufacturer of the drug to wipe out that cost, not only for the city, but for the members. So I guess I would argue this year alone, we're gonna wipe out over $300,000 in costs the city would have otherwise had an expense for, as it relates to prescriptions. And again, when you talk about your overall spend, it's not a small chunk of change. The other thing that I think is really critical is, again, it does come to education. Educating your employees, their spouses, and their dependents, especially as they go through the healthcare journey, to make sure that they are making good consumer healthcare choices. So again, I guess, and this will be something that I would love to continue to prove, is that the solutions that have been in place are solutions that most employer groups in your size, they don't have advantage of. You could not go to Quantum by yourself, because Quantum will only work with groups under over 1,000 employee lives. So I guess I'll leave that point there, and I think this will be something good that I think we should continue to discuss throughout the year. But I do think the city has been monumentally aggressive in trying to keep costs down from that perspective. And again, I know that's open for dialogue and discussion.
Oh, I don't think I have any other questions. Just thinking out loud.
I think those are great questions. Yeah, go ahead.
Spencer, just kind of curious, the company that you're recommending, is that a United States company?
So, so HCC is, and I'll double check, actually, I don't think I've ever been asked that question, but I'm pretty sure they're domiciled in the United States, but I will double check. So HCC did get purchased by Tokyo Marine, so there probably is gonna be a few foreign elements in there, but I know that HCC itself, is a US-based company, but I will actually double check, that's a good question.
Okay, thank you. I'd like to know that.
You bet.
Seeing no other questions, Spencer, unless you have any last statements, I think we're done.
No, it was great. And again, I just want to say, I appreciate the questions. I think these have all been, very insightful questions. Like I said, I think that I'll have a few follow-ups from here, and I'll work diligently with Matt on those, and make sure we get those distributed to the council members, because I think that they're pertinent questions.
We appreciate your effort. Thank you very much. Have a great evening. Meeting is adjourned, everyone. Thank you.
Appreciate everybody's time.
Everyone drive safely going home. Wherever you're going next.
Head to the bar, aren't we?
I flipped this one.